Okay, so I'll start with talking about corrected calcium, because right at the outset I want to tell you, सबको बताना चाहता हूँ कि calcium अगर correct करने के लिए अगर albumin है हमारे पास, तो every decrease in albumin by 1 gram हम calcium में 0.8 milligrams per deciliter calcium add करते हैं, तो उससे corrected calcium आता है. And whenever we're looking at calcium phosphorus abnormalities, तो साथ में और electrolyte abnormalities देखना भी जरूरी है. So calcium, phosphorus, albumin, magnesium, parathyroid hormone, PTH, और vitamin D, 25 hydroxy vitamin D. और इन सारों को साथ में लेके we can get an idea कि क्या problem है. तो अगर calcium and phosphorus दोनों low हैं, तो it's likely that vitamin D level भी low होगा और vitamin D देने की जरूरत है. अगर calcium low है, phosphorus high है और PTH भी high है, तो पहले phosphorus target कर सकते हैं. Again, depending on कितने क्या levels हैं कितना है, but अगर high phosphorus को पहले target करें और उसके बाद high PTH को target करें, तो that can be a strategy. पर अगर calcium भी high है, phosphorus भी high है और PTH भी high है, so that's likely tertiary parathyroid, hyperparathyroidism. तो उसमें पहले PTH को target करके हम PTH कम कर सकते हैं. So going on to a case, so this is a 62-year-old man जो dialysis पे है, end-stage kidney disease due to hypertension, peripheral vascular disease, and routine dialysis के लिए आया है, and out of different medicines उसमें वो cinacalcet ले रहा है, calcium acetate ले रहा है और pericalcitol ले रहा है. And उसके lab results में serum calcium elevated है 11.2 और last month 10.2 था. Serum phosphorus भी high है 5.8, last time 5.6 था, और parathyroid hormone 475 है. So before we go on to see how we will tackle this case, let's look at the Kdg guidelines. So what do the guidelines say? So it's important that the treatment should be based on serial assessments. So not just one value, but serially अगर आप पिछले 3 महीने या 6 महीने की values देखेंगे, तो जो उसका trend है, वो trend देखना important है. Maintaining normal calcium. So Kdg कहता है कि you should maintain normal calcium. Kdog कहता है that preferably it should be less than 9.5 milligrams per deciliter. You should treat high phosphorus. And what is high phosphorus? If it's greater than 5.5. And how to treat it with binders, with limiting the dietary intake. And we'll talk more about it. Treat the vitamin D deficiency with either cholecalciferol or ergocalciferol. And then dialysate calcium concentration. So the recommendation is to keep it between 2.5 to 3, as this is the most physiological. What are the symptoms due to hypercalcemia? So hypercalcemia symptoms can be bone pain, confusion, drowsiness, decreased level of consciousness, loss of appetite, nausea, constipation. And signs may it could lead to a short QT interval on EKG, hypertension, arrhythmias, and bradycardia. So हमारे patient में we saw कि calcium was high, phosphorus was also high, but he was on calcium acetate. So what we can do is we can transfer him or transition him to a non-calcium phosphorus binder like Sevelamer. He was on pericalcitol, but on a higher dose, so we can reduce the dose to allow the calcium to be slightly lower. He was also on cinacalcet. So cinacalcet reduces calcium and reduces PTH. So we can increase the cinacalcet dose, but here we have to be careful कि PTH ज़्यादा कम ना हो जाए, because PTH was 495. It's within normal range, but we don't want it to be too low. We should do dietary counseling about not eating a very high calcium diet. And if it's still not successful, the strategies, these 4 strategies, then we can try to lower the dialysate calcium concentration for some time, not persistently low, but we can try to keep it 1.5 to 2 for 3 to 4 weeks, and then go back to 2.5, which is more physiological. So this is hypercalcemia. Looking at another case, this is 45-year-old man on dialysis. He's had persistent itching, and his lab parameters show a very high calcium, 11, high phosphorus, but very high PTH, 1300. And reference range, different labs में different हो सकती हैं, but in this lab, this was 12 to 72. So even if we say 2 to 9 times, so this is much higher than 2 to 9 times of the upper normal of reference range. Alkaline phosphatase was high, so it's that it's a high bone turnover, and serum albumin is 3.2. So if you try to correct the calcium will be close to 11.5. Again, Kdg guidelines kya kehta hai? So even with parathyroid, the range should be between 2 to 9 times the upper limit of normal. So it's a wide range. Agar reference value 100 hai, to 200 से 900 के बीच में the PTH can be maintained. But if there are marked changes, so 200 से 500 जा रहा है, so we shouldn't wait कि 500 से जब 1000 जाएगा, only then we should add, because it's a significant change and rise. We should anticipate that it'll go even higher. So uske pehle se we can act on it. And then if we require a PTH lowering therapy, calcimimetics like cinacalcet, calcitriol, or other vitamin D analogs, and a combination of these can be used. So in this case, again, calcium is high, so we'll avoid using vitamin D analogs right in the beginning. But we can start with cinacalcet, we can start with non-calcium phosphorus binders, and then once the calcium and phosphorus are in reference range, we can start a low-dose vitamin D analog and try to tackle PTH with a combination of cinacalcet and vitamin D. But PTH agar persistently high rehta hai, in spite of this, then we worry about adenoma. So we can do an imaging, ultrasound, CT, or a scan, and then refer for subtotal or total parathyroidectomy if that is what is indicated. But agar PTH बहुत ज़्यादा कम हो जाता है, so अगर हम नहीं सब करो PTH बहुत ज़्यादा कम हो गया, तो we should, especially if it's less than 2 times upper normal, then we should reduce the cinacalcet and reduce the vitamin D dose, so that we are not overly suppressing the PTH. This is another case, a man on dialysis, young man who does dialysis for 3.5 hours, but he cuts short a lot of treatments. He misses a lot of treatments. He does not take his medications. And his calcium is low, his phosphorus is very high, his PTH is higher than than reference range, and higher than even 9 times normal, and his albumin is slightly low. So high phosphorus mein kya karenge? We should really do a very strong dietary counseling to avoid dietary phosphorus intakes, because that's the most important source of phosphorus for patients on dialysis or patients with kidney disease. So, but then we should use phosphate binder, and although non-calcium binders are preferred, but recent data has shown head-to-head comparison and systematic review, a Cochrane review, that the data that there are similar outcomes, but we should avoid calcium containing binders if there is persistent hypercalcemia. Calcium higher, so definitely we should avoid. Or if there are calcification, vascular calcification, or on the echo if there are valve calcifications. We should always counsel ki phosphate binder meals ke saath lena chahiye and not in between meals. Aluminum containing phosphate binders are very effective, but they have side effects, so we should not use it unless it's very high and none of the other binders are working, but the use should only be restricted for 4 to 6 weeks. Dialysate water should be checked for aluminum, and frequency of dialysis. So amount of dialysis can really affect phosphorus removal. So we should consider daily, nocturnal, or home hemodialysis, or we can consider increasing the time or increasing the dialysis surface area or using high flux dialyzers. Just talking about hypocalcemia, not going into a case, interest of time, but just hypocalcemia is less than 8.5 corrected calcium, and ionized calcium less than 4.2. And ionized calciums are more accurate, but as I said, corrected calcium using albumin, say you can make an estimate of what the corrected calcium is. And symptoms of really are when ionized calciums are very low, which are less than 2.5, and you get paresthesias, numbness, muscle cramps, weakness, reflexes are increased, and QT interval can on the EKG would be increased. But it can also lead to seizures, tetany, and heart failure if the ionized calcium is very low. And again, causes could be inflammation, infection, vitamin D deficiency, low albumin levels, hungry bone syndrome, which can happen after parathyroid surgery. and the medicines that we have started on them, cinacalcet, denosumab, or bisphosphonates. If the calcium is very low and severely low, and their patients are symptomatic, we should give 10 ml of 10% calcium chloride. But if there's mild to moderate, we can start vitamin D analogs. We can switch to calcium-based phosphate binders. Low magnesium level can also make hypercalcemia worse, so we should correct low magnesium. And then we can use higher calcium, dialysate calcium just for short term, because again, long-term high dialysate calcium can cause vascular calcification. So we don't want to use it for long term. Talking about hypoalbuminemia, which is very important because low albumin is a strong predictor of outcomes in dialysis patients. And less than 3.8 could be a criteria for protein energy wasting. But again, this is just a criteria based on studies. But really, if it's really low, less than 3, that is severe hypoalbuminemia that should be acted upon. And since the half-life is 20 days, so every month, if we check it, that can be a marker of their inflammation, infection, or just their nutrition. And why are patients not eating? That's an important question. So we should consider, are they not being dialyzed enough? And that's why they're not eating. Are they in heart failure? Do they have cirrhosis? Do they have an infection? Medications, if they are taking a lot of binders, a lot of iron, vitamin supplements, iron causing constipation, that can affect their appetite. So we should try to reduce it just for short term so that their appetite can improve. Or are they depressed? And depression is a big factor of a big risk factor for hyperalbuminemia because of anorexia. So if the albumin is really low, less than 2, then they can receive 20% albumin, 100 ml, can give 2 doses over 30 minutes apart. And then in general, KDIGO recommends protein intake 1 to 1.2 grams per kilogram. And at least 50% of this protein should be high biological value. So egg white, fish, chicken, milk and milk products, paneer, curd, and lentils, kidney beans. These are all high biological value protein, and this should be 50% of the protein intake in a day. And they should be encouraged to eat high protein food during dialysis, especially after 30 minutes of starting dialysis, to increase their protein intake. There can be oral supplements that have high dense calorie intake with very low electrolytes and very low volume, very low fluid, or they can get alpha keto analogs, and the dose can be between 6 to 14 grams per day. If their energy intake is really low, between 20 to 25 calories per kilogram per ideal body weight, and if the protein intake is between 0.8 to 1, then they can be referred for an intradialytic parenteral nutrition. And if it's even lower than that, less than 20 kilocalorie per kg per ideal body weight, or if the protein intake is really low, less than 0.8, they can be referred for TPN. So in summary, it's the trend of calcium, phosphorus, and PTH is more important than absolute value. Correct the high phosphorus by binders, diet, and amount of dialysis. Correct high PTH by vitamin D analogs and cinacalcet. And correct high calcium by avoiding calcium-containing binders and adjusting vitamin D analog dose. And then identify then correct protein energy wasting early. Since you're seeing the patient so frequently, you can identify if they're developing undernourishment, and then encourage adequate protein intake. Thank you.